Hi, I'm Anne Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Last week, we went into the epidemiology, diagnosis, and complications of placenta previa. This week, we'll cover management in the form of a case. So let's get into it.
We'll start in the antenatal clinic. Let's say you're seeing Donna for her antenatal booking-in visit. Donna is a 32-year-old G2P1 at 24 weeks gestation. She's had one previous caesarean section, and her morphology scan shows a complete anterior placenta previa overlapping the os by 15 millimetres. How would you counsel Donna?
I would start by explaining the diagnosis of placenta previa to Donna and why it can be an issue. I'd explain that a placenta previa means the placenta is covering the cervix, and this may mean that the baby needs to be born by a caesarean section, as you can't deliver a baby placenta first. I would also explain that in most cases, the placenta actually moves up and out of the way, and if that's the case, then she will be able to have a vaginal birth. I would then arrange a repeat ultrasound at 32 weeks to assess whether the placenta previa is persistent or if it's now clear of the os. Knowing that Donna has had a previous caesarean section and that this placenta is covering the os, I'm also suspicious that there's a higher chance of this placenta previa persisting later in the pregnancy. I would also want to make sure that there are no features of placenta accreta, especially with the placenta being anterior and over the caesarean scar.
So Donna is really interested in knowing more about the probability of her placenta previa resolving. Based on her ultrasound findings, what are the chances of Donna having a persistent placenta previa at delivery?
Well, the important feature in this case is the amount of overlap of the placenta over the cervical os. To recap from our last episode, the chances of a persistent previa depend on the distance over the os. If the overlap is less than 14 millimetres, almost 100% will resolve by delivery. If the overlap is 14 to 25 millimetres, like in Donna's case, about 20% will persist. If the overlap is over 25 millimetres, there's a 40 to 100% chance it will persist. And if the overlap is over 55 millimetres, there is about a 100% chance of persistent previa at delivery.
So Donna asks you if there is anything she can do to help the placenta to move.
Unfortunately, no. There's nothing Donna can do to increase the chances that her placenta previa will resolve before delivery. Although there are steps she can take to avoid complications of placenta previa, specifically bleeding. Donna should avoid intercourse or placing anything inside the vagina because it can trigger bleeding. She should also avoid strenuous activity or exercise, heavy lifting, or standing for more than 4 hours at a time, because studies have shown that these activities are associated with an increased risk of preterm birth. Donna should be advised to come into the hospital if she does experience any vaginal bleeding, which, as we said in last week's episode, happens in 90% of cases of placenta previa. 1/3 before 30 weeks, 1/3 before 36 weeks, and 1/3 after 36 weeks.
All right, so you complete your booking visit and arrange a repeat ultrasound at 32 weeks to check for persistent placenta previa. Donna is well counselled on pelvic rest and off she goes, usually with a very disappointed partner.
Yeah, sex can be quite a big thing for couples. Usually it's the males that are disappointed, but it can actually be quite disappointing for women as well. Sex is an important part of keeping intimacy in a relationship, and waiting 12 weeks to see if the placenta becomes clear can feel like such a long time. Is it ever okay to repeat the ultrasound earlier to see if the placenta has moved?
The reason we delay the repeat scan until after 32 weeks is to allow for enough time for the placenta previa to resolve. Performing a scan earlier might show a resolution of the low-lying placenta, but equally, the low-lying placenta might still persist, meaning that you still need another scan at a later gestation. Obviously, an earlier diagnosis of resolution would alleviate maternal anxiety and allow couples to resume an intimate relationship earlier in the pregnancy. But we also need to consider the impact of ordering additional ultrasounds on our resources, otherwise we might not be able to get scans when we desperately need them. If a patient is requesting an earlier ultrasound, then one option could be for them to get it done through a private radiology provider at their own expense.
All right, so Donna and her partner agree to a repeat ultrasound at 32 weeks gestation and understand the importance of avoiding penetrative intercourse, which means both vaginal and anal intercourse. Right before leaving, Donna asked you if it's still okay to do foreplay. Are there any risks from Donna having an orgasm from external stimulation?
UpToDate actually recommends that patients should be advised to avoid any sexual activity that may lead to orgasm. The rationale is that orgasm may be associated with transient uterine contractions, which could provoke bleeding, although there are no published studies that actually address this advice. There is a 2018 article that looks into the evidence behind recommendations for sexual activity restrictions for high-risk pregnancies. It's actually pretty interesting and discussed how different types of sexual intercourse can affect the pregnancy. In the case of placenta previa, the main things we worry about are direct contact with the cervix or placenta that may trigger bleeding, direct contact to the lower uterine segment which could place it under stretch and trigger bleeding, release of prostaglandins from semen or cervical manipulation which can lead to cervical ripening and opening, and release of oxytocin from maternal orgasm which may stimulate uterine contractions, triggering bleeding.
Now, the important thing to note here is that although these seem to make physiological sense, they're really just theories, and there's no strong evidence to support or refute the recommendation to avoid intercourse and sexual activity during a pregnancy with placenta previa. The 2018 article Sexual Activity in High-Risk Pregnancies by Sally McPhedran suggests the following approach. Sexual activity of any type does not need to be restricted until the cervix length is less than 3 centimeters, after the sentinel bleed, or if the baseline uterine contraction frequency or intensity increases. After the sentinel bleeding episode, penetrative sexual acts and any sexual activity leading to the patient perceived uterine contractions or painful contractions should be avoided. Non-penetrative sexual activity that does not result in patient-perceived uterine contractions or painful contractions need not be restricted after the sentinel bleeding episode. Further research is needed to make a validated recommendation. Now remember, this is the opinion of one author of one article. We've all worked in a maternity assessment unit, and how often do patients come in with bleeding after intercourse? All the time. We've definitely had patients come in with bleeding after an orgasm as well.
So long story short, we don't have any good data to say, yes, it's definitely safe to have sex. But we do have some extrapolations based on previous knowledge, which suggests it might not be a good idea. For now, the general consensus of most guidelines seems to be to avoid sexual activity until the ultrasound confirms that the placenta is clear of the os.
Okay, so you're now working in the maternity assessment unit and you see Donna's name pop up on the triage screen. Donna is now 31 weeks pregnant and has been brought in by ambulance with a large antepartum hemorrhage. How should you manage this presentation?
So first I would attend Donna immediately. A large antepartum hemorrhage is an obstetric emergency, and so I would hit the emergency buzzer to call for help. I would take a doctor's ABC approach, checking for danger, making sure I'm wearing my PPE, and ensuring Donna is responsive and conscious. I'd make sure Donna has a patent airway and that she is also breathing. From a circulation point of view, I would check her pulse and blood pressure and insert 2 large bore cannulas and consider inserting an IDC. I would send off bloods, including a full blood count, Chem 20, group and hold, coags, cross-match, and Kleihauer. I would initiate IV fluid resuscitation with normal saline, but also consider activating the massive transfusion protocol if her hemorrhaging is severe. I would aim to perform simultaneous resuscitation while taking a targeted history and doing an assessment. In particular, I'd want to talk to Donna about how much blood she's lost, when did it start and is it ongoing? Was there any precipitating event like abdominal trauma or intercourse? Does she have any associated abdominal pain or contractions that might indicate labour or placental abruption? Is the baby moving normally? Has she had any fluid loss indicating PPROM? And does she have any signs or symptoms of preeclampsia, which can also be associated with abruption? The next thing I would do is move on to examination. I would check Donna's blood pressure and heart rate to make sure she is hemodynamically stable. I would assess her abdomen to make sure it is soft and non-tender, again looking for signs of labour or placental abruption. I would also put on a CTG to assess the fetal heart rate. We should also attempt to quantify the blood loss through visual estimation and by weighing the soaked sheets in the department. The next thing I want to do is a speculum examination. Remember, we're not doing a vaginal examination because I don't want to poke the previa and make it bleed. The point of the speculum exam is to assess the presence of ongoing and active bleeding as well as the volume, to determine whether the bleeding is coming from the cervical os or whether she has a bleeding ectropion or polyp, and to check whether the cervix is open and whether she is in labour or not. Once I've done my basic assessment, my initial goals would be to ensure maternal hemodynamic stability, to ensure stability of the baby, and to determine whether emergency caesarean delivery is indicated or whether conservative management is more appropriate.
Okay, so you do your initial assessment. Donna had an unprovoked bleed of about 700 mils at home, and she's had a further 200 mil loss in the department. She has no abdominal pain or contractions, and her baby is moving normally. There's no history of abdominal trauma, intercourse, or fluid loss otherwise. Her obs are normal, her abdomen is soft, non-tender, and the CTG is reassuring. On spec, you expel some clots from the vault and see a slow trickle of blood from the os that appears to settle. Her cervix appears closed. Her hemoglobin is 70, Chem 20 and coags are normal, and the Kleihauer is negative. Her blood group is O negative. What do you do now?
Okay, so given mum is hemodynamically stable and the CTG is normal, there's no urgent indication for delivery. The first thing I would do is initiate a blood transfusion to restore her hemoglobin. I would then administer anti-D, given that her blood group is O negative. Remember, she's likely to have had her 28-week anti-D 3 weeks ago, but this doesn't matter if she's had a new bleed. The point of routine anti-D is to cover any occult fetal maternal hemorrhage throughout the pregnancy, and additional anti-D is required for sensitizing events. In this situation, anti-D is indicated. The next thing we need to do is consider admission. This is the standard management for most significant antepartum hemorrhages. If you're seeing a lady with an antepartum hemorrhage that is provoked from intercourse and it's very small, and you do a speculum exam and you can't see it's clearly from an ectropion, then these women don't always need admission, but in general, anyone who has had a decent antepartum hemorrhage or bleeding placenta previa would warrant an inpatient stay. I would also make sure the CTG stays on if there is ongoing active vaginal bleeding.
Okay, so just to clarify, you said that because mum is stable and the CTG is fine, that there's no urgent indication for delivery. What are the indications for delivery in this situation?
In the context of a bleeding placenta previa, the indications for delivery would be active labour, an abnormal CTG unresponsive to resuscitative measures, and severe and persistent vaginal bleeding where maternal hemodynamic stability cannot be achieved or maintained. There is also an argument that significant bleeding after 34 weeks gestation would be an indication for delivery. After 34 weeks, the balance of fetal benefit versus maternal risk favours delivery because the neonatal benefits from avoiding preterm birth decrease with advancing gestation, and the maternal risks from persistent or recurrent bleeding increase. Although it's important to know that the exact gestational age threshold and amount of bleeding considered significant are matters of clinician judgment. The decision to deliver these pregnancies is made on a case-by-case basis.
I think it's also important to point out that patients under 34 weeks who are hemodynamically stable or quickly stabilised and have a normal CTG are candidates for expectant management. People often panic with a large bleeding placenta previa and sometimes jump to a delivery too soon. This can be quite understandable when you've got a lady who comes in and has lost a litre of blood and has ongoing bleeding. But actually, if the patient is stable, and you can manage these patients with a blood transfusion in the first instance. Terrifying, I know, but this approach has been shown to reduce the incidence of preterm birth from bleeding previa. UpToDate suggests that your first-line management should be a normal saline bolus. If tachycardia or hypotension is not rapidly corrected with this, or if the hemoglobin is less than 100, then you should proceed to an immediate blood transfusion. Remember that pregnant women are often young and healthy, and they have an amazing ability to compensate for large volumes of acute hemorrhage. They may not be tachycardic or hypotensive until they've lost a significant amount of blood. So if your patient is symptomatic, they've probably lost a lot of blood. So it's reasonable in these instances to jump straight to a blood transfusion. Most patients who present with a bleeding placenta previa will respond to supportive therapy and do not require immediate delivery. What we want to do is prolong the pregnancy to allow fetal growth and development without placing the mother at excessive risk from persistent or recurrent bleeding. Now, we recognise that this can be a difficult decision, but when you've got a patient rocking up at 3 o'clock in the morning with a heavily bleeding placenta previa, it's something to keep in the back of your mind.
UpToDate also suggests that your target hemoglobin after transfusion should be 100. This allows a margin of safety since the patient is at increased risk for another, more severe bleeding event. However, if there's an immediate need for delivery, a pre-operative or intra-operative target hemoglobin of 80 is also reasonable. Okay, so back to Donna. I just want to raise a quick point. We spoke about anti-D and the need for more anti-D during a sensitizing event, but is that applicable for placenta previa? You know, we have these patients who come in, they have their first bleed at 28 weeks, they'll stay in the hospital for a couple of days, have another bleed the next day, have a bleed the day after that, go home, come back a week later with more bleeding, go home, etc. Like, these patients are often presenting multiple times in their pregnancy. Do these women need anti-D every single time?
Okay, so this is a little bit of an area of debate. I know in our anti-D episode, we said that every time there is a new event that we should give repeat anti-D. Now, obviously that's the case with abdominal trauma or placental abruption, or if they have a procedure, basically any kind of new different event. When it comes to placenta previa, it's a little less clear. The expert reference group in Australia recommend anti-D for each occasion of revealed or concealed antepartum hemorrhage. But in the same table, they also state that for ongoing uterine bleeding alone beyond 12 plus 6 weeks gestation, a repeat dose of anti-D may be appropriate at 6 weekly intervals. So which category do recurrent bleeds for placenta previa fall into? UpToDate suggests that for placenta previa, re-administration is not necessary if rebleeding occurs within 3 weeks of additional anti-D administration. If repeated episodes of bleeding do occur, the anti-D antibody titer could be checked. If a low titer is still present and the CLIHAR is negative, then the patient is covered and additional anti-D does not need to be administered. If anyone in the audience can clarify what your hospital policy is on this for our listeners, please let us know.
Yeah, very interesting. Okay, so our management so far has been resuscitate and stabilize, exclude urgent indications for delivery, admit, correct anemia, and administer anti-D. What now?
So now we would also want to consider steroid loading. In Queensland, antenatal corticosteroids are indicated between 22 to 34 plus 6 weeks gestation. Between 35 and 36 and 6 weeks administration, it's a little bit more controversial and warrants a discussion with the patient on risks versus benefits. Check out our podcast on antenatal corticosteroids if you want to learn more about this. If urgent delivery is indicated under 30 weeks gestation, we would also ideally commence magnesium sulfate. However, in the event of an acute hemorrhage requiring immediate delivery, I certainly would not be delaying delivery to initiate this. With admission, I would recommend regular observations and pad checks, CTG at the time of any bleeding, and I would arrange a repeat ultrasound to confirm persistence of the placenta previa.
I do notice that we tend to arrange a fetal growth and well-being ultrasound every time someone presents with an antepartum hemorrhage. Why is that?
Well, the first thing we're looking for is to confirm persistence of the placenta previa. We're also looking for any evidence of decidual hemorrhage causing placental separation, such as in the case of placental abruption, and whether the cervix is showing any signs of cervical insufficiency, such as a shortened length, dilated os, or prolapsed fetal membranes. Remember, ultrasound has a low sensitivity for the diagnosis of abruption, so even if someone is abrupting, you won't always see evidence of this on the scan. Fetal growth can also be assessed at the same time. An asymptomatic placenta previa is not in itself an indication for serial growth scans. Recurrent antepartum hemorrhage that is unexplained or due to placental abruption is an indication for serial growth scans due to the increased risk of fetal growth restriction. Bleeding placenta previas fall into a bit of a grey area. On the one hand, you know the bleeding is coming from the placenta, and so the ABH is not unexplained. On the other hand, you could argue that the bleeding is due to separation of the placenta over the cervical os, which is similar to an abruption and arguably has a similar impact on fetal growth. There is a 2016 study which looked at placental histopathology and pregnancy outcomes in pregnancies complicated with symptomatic versus asymptomatic placenta previa. They found that symptomatic placenta previa is associated with increased placental malperfusion lesions, suggesting an association of maternal malperfusion with abnormal placental separations. Patients with a retroplacental hematoma also appeared to have worse outcomes. In general, no guideline mentions whether to arrange serial growth ultrasounds or not for bleeding placenta previas. We recommend considering this on a case-by-case basis with reference to your local hospital policy.
Okay, so Donna is admitted overnight. She has one further bleed of about 20 mils on the ward, and then that settles for a further 48 hours. Her ultrasound demonstrates persistent anterior placenta previa with otherwise normal growth and a long cervical length. We managed to get her hemoglobin to 100, and she remained stable. We use blood products in this case because of the massive hemorrhage, but iron infusions or oral iron supplementation can also be considered. When can Donna go home?
So in Australia, we generally opt for outpatient management once the patient is stable and has met certain criteria. Ideally, we want the bleeding to have stopped for at least 24 hours. We'd like to make sure Donna lives nearby and is able to get to the hospital again if she should experience any further bleeding. If Donna lived on her own or in the middle of nowhere, then we might look at arranging local accommodation or a prolonged inpatient stay, depending on her circumstances.
So I was always taught that patients are at an increased risk of bleeding the first 24 hours after a major bleed, which is why we want a good 24 hours without bleeding prior to discharge. But it seems this is more of a good practice point and not really based on any evidence. Where does this recommendation for 24 hours of no bleeding come from?
You're absolutely right. There is no strong evidence for the time frame of 24 hours with no bleeding. Previously, bleeding placenta previas were managed as inpatients until the ultrasound demonstrated resolution of the placenta or until delivery. In fact, it used to be normal to admit all patients with placenta previa in the third trimester, even if they were asymptomatic. Because of limited maternity beds, as well as the impact prolonged hospitalisation was having on women, people started looking into whether patients could be managed as outpatients instead. Initially, the recommendation was that asymptomatic patients with placenta previa could be safely managed as outpatients, but patients who had bleeding should remain admitted. After a while, studies came out that demonstrated the safety of outpatient management for bleeding placenta previas after 48 to 72 hours of observation. Currently, most hospitals support a policy of discharge once the bleeding has stopped for 24 hours, and this approach is also backed by UpToDate. Consideration should be given to hospitalisation in women who present with 3 or more bleeding episodes, since these patients have about a 40% chance of requiring emergency delivery. Being in close proximity to the labour ward may also allow quick access to blood transfusion and delivery in the event of a major hemorrhage.
Okay, so that sums up our management of bleeding placenta previa. Doctor's ABCD approach with a targeted history and exam, maternal resuscitation and stabilisation with blood or fluids, determining that if there is a need for delivery or whether the patient is suitable for expectant management, deliver or admit, correct anemia, corticosteroids, anti-D if rhesus negative, and fetal growth ultrasound.
All right, so Donna's bleeding resolves and she's had no further bleeding episodes during her pregnancy. She's now 36 weeks and wants to talk to you about delivery. Her most recent scan at 36 weeks shows persistent placenta previa. What are our considerations for delivery?
Let's break this up into mode of delivery, location of delivery, and timing of delivery. Clearly, Donna needs a caesarean section. A vaginal birth is not possible with a placenta previa. Ideally, this would be done in a hospital with appropriate theatre facilities, access to ICU, and a blood bank. As this is a high-risk delivery, it's important to have experienced obstetric, anaesthetic, and paediatric teams available. Timing of delivery for an uncomplicated placenta previa is recommended between 36 and 37 plus 6 weeks gestation, although this recommendation does vary. There is mounting evidence that delivery in the early term period is better than the late preterm period, and so many hospitals will aim for delivery between 37 and 38 weeks.
Okay, so timing of delivery is 36 to 37 plus 6 weeks. Mode of delivery is via caesarean section, and location of delivery is a hospital with theatre facilities, ICU access, and a blood bank. What are our other pre-operative considerations?
Obviously, we would want an anaesthetic review given that this is a high-risk pregnancy. Regional anaesthetic is fine for a stable placenta previa, but general anaesthetic is generally preferred for unstable patients or those with massive bleeding. Patients who have an increased suspicion of placenta accreta, for example, those with multiple previous caesarean sections, may also be best managed under a GA. The anaesthetist should always be ready for the possibility of conversion to a general in the event of a massive hemorrhage. A preoperative anaesthetic review allows our anaesthetic colleagues time to assess the patient and make an anaesthetic plan in advance. There's nothing worse than being called to a Cat 1 Caesar for a lady with a bleeding placenta previa in somebody who you've never met before.
Consent is, of course, another important element of preoperative planning. Caesarean for placenta previa comes with increased risks compared to other Caesars, and it's important that the patient is counselled on this. The consent should cover the increased risk of bleeding, requirement for blood transfusion, possibility of back reballoon, stepwise devascularization of the uterus, and the possibility of hysterectomy. There's also a risk of infection, damage to bladder, bowel, vessels, or the baby. A previous RANSCOG exam question has asked for the risks at caesarean section and their frequency. A really good example of this can be found if you Google ARCOG placenta previa consent form, but some important stats to remember are these. There's a 6% risk of bladder or ureteric injury, a 21% risk of massive obstetric hemorrhage requiring transfusion, 11% risk of emergency hysterectomy. This increases to 27% if there's a previa and one previous caesarean section, and a 7.5% risk of further laparotomy during recovery.
Anticipating and preparing for bleeding is another important preoperative consideration, and as Carla just mentioned, can happen in up to 21% of caesarean sections for placenta previa. The hemoglobin should ideally be optimized prior to delivery. We would typically arrange a cell saver in advance and ensure we have a valid group and hold and a cross-match of at least 2 units of blood available. The blood bank should also be made aware of the case and be on standby in case of any significant bleeding requiring activation of the massive transfusion protocol. The theatre should also be prepared for the possibility of the need for Bakri, B-Lynch sutures, or a hysterectomy and have this equipment readily available. The patient should have 2 large bore cannulas inserted, and in some cases, additional monitoring like an arterial line might be recommended.
I sometimes have patients who are at high risk of needing a blood transfusion ask me if it's possible to donate their own blood during pregnancy to be given back to them later. Is this a possibility?
So what you're talking about here is autologous blood transfusions. This is a service that is provided by the Red Cross. However, it is restricted for exceptional circumstances. The only patients who are able to access autologous blood are those with a rare blood group or multiple red cell antibodies whose transfusion requirements cannot be met with allogenic blood. The Australian Red Cross Blood Service does not provide this service for those who do not meet these criteria. The New Zealand Blood Service also offers this in exceptional circumstances, however might impose a charge to cover the full costs of providing the service for other situations. It's important to note that pre-op autologous donation is not risk-free. Although it reduces exposure to allogenic red blood cell transfusion, it does increase the risk of receiving any red blood cell transfusion. It carries the same risks of donation as well as some of the risks of allogenic blood, for example, bacterial contamination, incorrect blood being given due to collection errors, and febrile reactions. It also increases the risk of pre-op anemia that is associated with worse outcomes. When autologous blood is collected, about 50% of the time the blood will not be used, contributing to wastage of blood products.
It's also important to anticipate neonatal resuscitation and ensure a skilled paediatric team and neonatal resuscitation equipment is present at the delivery. There is an increased risk of fetal anemia if delivery is required through the placenta, and so again, the paediatricians and blood bank need to be made aware of this.
Prior to the delivery, I'd also perform a bedside ultrasound to localise the placenta. What I'm looking for is whether there is a window without the placenta that I could use to enter the uterus rather than cutting through the placenta, which increases the risk of fetal and maternal hemorrhage. I also want to know where the nearest placenta edge is, in case I want to reach my hand around the placenta to deliver the baby. Ultrasound is also useful to assess the fetal presentation. Malpresentation is increased with placenta previa, and I like to be prepared if the baby is in breech or transverse lie.
So preoperatively, we want consent, anaesthetic review, optimise hemoglobin, anticipate and prepare for bleeding, and perform a preoperative bedside ultrasound to localise the placenta and fetal presentation. What are our intra-operative considerations?
Intraoperatively, the first thing I ensure is proper patient positioning. In cases with the possibility of massive hemorrhage, it can be helpful to place the patient in lithotomy with a bagged drape underneath. This allows measurement of intraoperative vaginal blood loss, but also facilitates easy access in case insertion of a Bakri balloon is required. When performing the delivery, I would always keep an eye out for any signs of placenta accreta, especially since Donna has had a previous caesarean delivery. I would then enter the uterus, aiming to avoid the placenta where possible, or quickly cut straight through it if I have to. I then deliver the baby, sometimes with forceps if that head is high, and clamp and cut the cord immediately. Delayed cord clamping is not appropriate with placenta previa because of the risk of fetal bleeding and anemia. Once the baby and placenta are delivered, I'm then prepared for a postpartum hemorrhage. Often that lower segment is particularly vascular and you tend to get significant rapid bleeding. Judicious use of uterotonics and quick escalation to Bakri or B-Lynch may be required. I'm always attuned to the possibility of needing to activate a massive transfusion protocol or of progressing to hysterectomy.
You can also use hemostatic square sutures to help control bleeding from a focal area. The Affronte endouterine hemostatic square suture technique involves making 4 to 6 2x2 centimetre squares in the area of placental bed bleeding. The 1 vicral sutures should penetrate the decidua and myometrium but not go beyond the uterine serosa. In one study, this approach stopped PPH in 92% of cases. This approach does increase the risk of intrauterine adhesions, though, with about 20% of patients developing adhesions significant enough to require a resection.
Post-operatively, I would ensure appropriate disposition of the mum and transfer to ICU if needed. The hemoglobin would need to be rechecked and blood products replaced. I would assess her need for anti-D, remembering that if she has blood from the cell saver and the baby is rhesus positive, then she needs a Kleihauer done 45 minutes after the transfusion to guide additional anti-D requirements. I would debrief the patient and her partner, as well as the delivery team, and have a discussion on the implications of this delivery on subsequent pregnancies.
Okay, so to summarise delivery planning. For location of delivery, you want a hospital with good theatre facilities, ICU, and a blood bank, as well as an experienced obstetric, anaesthetic, and paediatric team. The timing of delivery is 36 to 37 plus 6 weeks for uncomplicated previa, and 34 to 37 weeks if a history of vaginal bleeding or risk factors for preterm birth. Mode of delivery is obviously caesarean section, keeping in mind the possibility of placenta accreta if there are previous caesareans. Pre-operative preparations include arranging an anaesthetic review, optimizing maternal hemoglobin, arranging a cell saver, ensuring senior obstetric, anaesthetic and neonatal staff are aware and present for the case, obtaining consent, including for blood transfusion, Baccarin and hysterectomy, and a bedside ultrasound to assess fetal presentation and placental location.
Intra-operative considerations include appropriate patient positioning, considering lithotomy positions and a drape, IV access, including the possibility of an arterial line, mapping and planning your incision site to avoid cutting through the placenta, anticipating fetal malpresentation, immediately clamping and cutting the cord to minimize fetal bleeding, and preparing for postpartum hemorrhage and neonatal resuscitation.
Postpartum, you want to assess maternal disposition, whether she's suitable for the ward or ICU, assess hemoglobin with a full blood count and correct anemia with blood or iron products, administer anti-D if it's required, and debrief the patient, her family, and the delivery team.
Now, there's one more thing we were discussing at work this week, and I wanted to touch on before we wrap up this week's episode. What's the deal with low-lying placentas?
So low-lying placentas are a different kettle of fish. We used to put low-lying placentas in the same category as placenta previa and recommend a caesarean delivery for everyone with a placenta within 2 centimetres of the cervical os. However, recent evidence has changed our practice. A systematic review called Vaginal Delivery in Women with a Low-Lying Placenta was published in BJOG in 2019. This review looked at 10 studies of nearly 600 patients with a low-lying placenta undergoing a trial of labour and reported outcomes by the distance between the placental edge to the internal os.
We're discussing this week at work. How timely. I'm glad we're now discussing it during the podcast.
So what this study found was that you basically break up low-lying placenta into 2 groups, so 0 to 10 millimetres and then 11 to 20 millimetres based on the distance of the placenta from the os. So with a distance of 0 to 10 millimetres, there's about a 43% chance of successful vaginal delivery and a 45% chance of emergency Caesar due to hemorrhage, so pretty similar risks. At a distance of 11 to 20 millimetres, there's an 85% chance of vaginal delivery and a 14% chance of emergency caesarean due to hemorrhage. Now, this compares to an 82% chance of vaginal birth with a 10% risk of emergency caesarean for those with a normally positioned placenta. Between the groups, there was no difference in blood transfusion or postpartum hemorrhage. As a result, the study went on to state that a low-lying placenta in asymptomatic patients is not a contraindication to vaginal delivery, and that a trial of labour should be recommended for women with a low-lying placenta with a distance of 11 to 20 millimetres from the os. If a woman with a low-lying placenta of 11 to 20 millimetres opts for an elective caesarean section, then this should actually be delayed until 39 to 40 weeks gestation. A trial of labour could also be considered in carefully selected women with the placental edge at 0 to 10 millimetres from the cervical os and without risk factors. Remembering that the risk of vaginal delivery is 43% and the chance of emergency caesarean is 45%. If after counselling the woman decides she'd prefer a caesarean section, then this should happen between 37 to 38 plus 6 weeks.
And that wraps up this week's episode of the Uterine Sound podcast. We hope you're all over the management of Placenta Praevia. Keep an eye out for our summary slides on Instagram later in the week. If you have any comments, feedback, or want to fact check us, please reach out on our email, theuterinesound@gmail.com. You can also reach us on Instagram and Facebook at The Uterine Sound and our website, www.theuterinesound.com.